Good morning, good afternoon, good evening, everyone. I'm happy to welcome you to this parallel session. I have to say it feels a little odd to be speaking to you just looking at a computer screen. I can't see your faces, but I hope everyone's as excited for this panel as I am. We're going to be learning from experience, confronting power inequality and corruption at the policy level. And so we have a nice diversity of speakers today. There's just 4 speakers, so we have ample time for a question and answer, and I hope you'll all engage in that actively. And we're going to look at, take different angles on the question of how to confront power inequality and corruption in policymaking and agenda setting. So we have an interesting mix of panelists. 2 of them are looking at tobacco control, and there's 2 that are looking from outside the ministries of health, so outside what we typically look at in thinking about health policy making, looking at the roles of civil society and parliament, and 2 who are looking more about these processes within ministries. So without further ado, I'd like to start by introducing myself. I'm Marta. I've worked in health and human rights for over 20 years with specific expertise in maternal health and accountability. You can read the rest of the details of my bio there. And I'll move on to the next slide. Thank you. So if you have any questions throughout the panel, you can access the support chat, which you can see right there. I'm not going to read all of this in detail. So if you haven't yet participated, you may just want to take a photo of this. I want to point out that there will be a live Q&A at the end that, as I mentioned, I hope will be fairly robust because we have a decent amount of time with 4 panelists. So please feel free to start engaging that whenever you want. I will be monitoring that and reading the questions aloud at the end. We also have the other discussion, the discussion forum, which we may use. So feel free to use that if you want to just share thoughts and not specific questions throughout. And I'm hoping the panelists will use it as well. And then the last 3 points relate to how to make sure that you can watch this in full screen, and then just to alert you to the fact that the sessions are being recorded and that you can view this starting tomorrow if you want to look at anything again. Next slide, please. So first, we're going to start with Dr. Laura Shambi. This presentation is in English, although the title is in Spanish. Dr. Shambi is a physician, researcher, and university teacher at the University of the Republic in Uruguay. She has been working in tobacco control since 2003 and has participated in and conducted several research projects regarding tobacco control and from a wide range of perspectives, including tobacco cessation, pregnancy, secondhand smoke, and tobacco flavoring. So you can see the rest of her details there, and I think we're ready to move on to Laura's presentation.
Well, good morning or good afternoon. My name is Laura Shambi. I'm from Uruguay, and I'm presenting this work of interinstitutional integration to support health policy implementation, the experience of the Advisory Committee for Tobacco Control in Uruguay. Those are my co-authors, and we belong to several institutions in Uruguay. The roadmap of this presentation is that I have no conflicts of interest to declare, and we are going to talk about a framework, the working methodology of this committee, and some diagnoses and actions that we propose for the following 5 years. For those actions, we are going to use the framework of Empower of the Framework Convention for Tobacco Control of WHO. So the framework for this committee was that it was created by the Ministry of Health Ordinance in 2004, and it includes representatives of the Ministry of Health itself, but a number of institutions where civil society, especially NGOs, professional institutions, and other NGOs are sitting there in this committee, as well as the Cancer Commission, Cardiovascular Commission, the academic sector, where from I belong, the University of the Republic, and then the national medical associations, the drug joint, and other institutions, state institutions and private institutions. So the working methodology of this advisory committee for tobacco control is that it designs 5-year strategic plans, have fortnightly meetings, and works with a pre-established agenda and some emergent issues. And it receives inputs and thoughts from the different institutional profiles. As I mentioned, there are a lot of institutions with different profiles. It arrives to consensus in its decisions, and it works using working groups, and it gives assessment to Ministry of Health in all that has to do with tobacco control and further legislation, laws, etc. All the work of this advisory committee stays in registries that are called acts, and in fact they are important. They were, for example, used in the legal challenge of big tobacco against Uruguay. Philip Morris International specifically challenged our country some years ago, and Uruguay was successful in this legal challenge, and lots of the registries of those evidence-based policies that were implemented were from this advisory committee that registered in its acts all the work that was done by those delegates. So moving to the part of diagnosis and action, as you know, the Empower is an acronym for 6 measures in a package of evidence-based policies and best practices for tobacco control. So we are going to go through the Empower in this strategic plan of 5 years of our advisory committee. The M stands for monitoring. As you can see, we are presenting the actions that were done in the period before, some relevant results of monitoring, and here I'm going to go through some of the data in the slide, like for example the decrease in prevalence in adults and youth of tobacco use. And we identified with the principle of leaving no one behind that there are still vulnerable population that we have to tackle and address. So the actions to be done in the following years have to be about monitoring in this group, low socio-economic status populations, the factors that are affecting tobacco use in these people. P of the Empower stands for protecting secondhand smoke. And here are some of the relevant results of the last 5 years with decreased exposure in general of our population to secondhand smoke. But it's still an issue and a public health issue among vulnerable population. And here you have some data we obtain in low socioeconomic status pregnant women that are in more than one third exposed to secondhand smoke in their homes. So this is the vulnerable population that we have to not leaving behind, and some actions to be done in the following years. The O of Empower stands for offering help to quit, and we have prepared, and it's already approved, a national cessation strategy with a lot of sub-plans and actions. Here are some relevant results about those actions. We have more than 100 tobacco cessation clinics throughout the country working in a standardized form for offering help to quit tobacco with pharmacological aids also. And here we identified the things that are to be done and the vulnerable population that is not yet covered by this strategy, and our plans for the next year that have to deal with extend the coverage in hospitalized patients, in vulnerable patients with TB and HIV, and ensure equity in the access to these tobacco cessation clinics. W stands for warning and has to do with tobacco advertising, promotion and sponsorship bans. We have a quite complete ban of these aspects, and we have health warning with pictograms in tobacco boxes. But we still have to move on to banning advertising and promotion in electronic devices that are increasing its use in young people in our country. For last, E and R stand for enforce and for raise taxes. And again, here we have actions that were done, some relevant results on these aspects, and the vulnerable population that needs to be covered, again, youth that is exposed in internet and in social networks to a lot of promotion and sponsorship, especially of electronic devices. And in our still vulnerable population get access to illegal market of cigarettes that are very cheap here in Uruguay. So we still have some actions to do regarding enforcement and regarding taxes in our country. So as a conclusion, the area has, and this committee particularly has enhanced the participation of lots of organizations, civil society, academia, professional associations, and state agencies in a health policy decision-making process. And it's like kind of tangible contribution of several institutions to a program, to the National Control Program of the Ministry that has limited resources, limited material resources, and limited human resources. And in this way, all delegates and all institutions contribute through this committee to this program. So integrated work from institutions from different profiles has contributed to diagnosis, advice, implementation, and actions in tobacco control in Uruguay, strengthening policy decisions. Thank you very much.
Thank you, Laura. That was a really interesting presentation looking at a multi-stakeholder advisory committee, and I hope that we can, during the Q&A, engage some questions related to participation in that committee and their role, their power that they actually wielded in agenda setting. Next, I'm pleased to introduce a second presentation relating to tobacco, and this is Amity Varma, who's going to talk about situating tobacco and health policy and the use of Parliament as an instrument of accountability. Amity is with the Institute of Public Health in India. She's trained in the discipline of psychology and works as a researcher at the Institute of Public Health, as I said, in Bangalore, and she has a wide range of research interests in the areas of mental health, public health, and development. Amity.
Good evening, everyone. My name is Amity, and I'm a researcher from the Institute of Public Health in Bangalore, India. I'm presenting this work on behalf of my co-authors. Tobacco is known to be the single biggest preventable cause of death and disease, yet it continues to be a part of a thriving and profitable industry. India is the second largest consumer of tobacco in the world, and it's also the third largest producer of tobacco leaf in the world, next only to China and Brazil, as shown in this graph. And it's a major source of livelihood and revenue. All of this makes it a significant public health challenge. There are strong regulations in place. India is a signatory of the WHO Treaty on Tobacco Control, signed in 2004, as well as having its own regulations at the national and state levels, including the Cigarettes and Tobacco Products Act, which came in place in 2003. Despite the strong regulations, the reduction in tobacco use over the past 20 years has been marginal. Our work presented here today is part of a larger project studying the political economy of tobacco. We have found limited empirical research on the extent and the nature of the role of the state in shaping tobacco control in India, making a case for further investigation. We sought to understand how tobacco is addressed and understood in the Parliament of India, the highest legislative body in India. It's a powerful institution with the potential to represent the voices of the people and demand accountability in public policy. We asked, how is tobacco understood and discussed by our elected leaders in terms of what are their concerns around tobacco and how is this framed in the Parliament? How have these interests around tobacco changed over time? And are there any geographical trends and patterns to these? The Indian Parliament consists of two houses, both of which conduct question-hour sessions where parliamentarians pose questions to the ministries, asking details about policies and government activities or administration. For our research, we analyzed these questions. The parliamentary questions asked form a large publicly accessible data set and a useful repository of information. As we have a screenshot of the question of the web page of the Parliament of India on the right. Using the keywords tobacco, we sourced the transcripts from the web portals of both the houses separately from the year 1999 to 2019. These transcripts were then organized and classified using NVivo software. We classified the questions based on the attributes of the date the question was answered and the ministry to which the question was asked, as well as attributes of the parliamentarians who asked these questions in terms of what state they were from and what political party they were affiliated with. And this is an example of a question shown on the screen here. And during the 20-year study period, from 1999 to 2019, we found that 729 parliamentarians asked 1,315 tobacco questions. We used thematic analysis of the content of the questions using open coding of data with inductive reasoning, guided by our research questions. When analyzed, we found our themes centered around 4 broad areas, the first being health concerns. Here there were questions around the consumption patterns of tobacco in terms of what population used what products. There were questions on the health harms of tobacco in terms of the extent and nature of harms. Questions around promoting tobacco cessation, the role and influence of media and communication, and understanding and monitoring tobacco control regulation. And finally, questions around the conflict between health goals and industry goals. This subtheme is particularly interesting as in many cases, the questions were asked quite explicitly. Moving on to the theme of trade concerns, the first questions were around the role and functioning of the Tobacco Board, a regulatory body in India, trends in tobacco markets around production and export trends, questions around tobacco taxation, clarifying questions about the tax rates, as well as questions about tax evasion by certain groups, and finally, questions around policy inquiries and implementation around trade. Moving on, there were further themes around agricultural concerns. This was around support available or required by farmers. Questions around the livelihood and welfare of tobacco growers and workers. These were concerns around working conditions for these growers and workers, as well as the negative impact of tobacco control measures on their livelihoods, as well as concerns around alternative livelihoods for those working in the sector. Beyond thematic analysis, we also analyze questions according to which ministry they were posed. In this graph, where we have plotted time on the x-axis, it was interesting to note that during the early years of the study, especially during 1999 to 2004, a majority of the questions were posed to the Ministry of Commerce and Industry, and very few, demarked in grey, were asked to the Ministry of Health and Family Welfare. This pattern has consistently changed over the 20 years, where the number of questions asked to the Ministry of Commerce and Industry have reduced, whereas those asked to the Health and Family Welfare have increased. And the implications of this show the shift in interest over 20 years. Though not depicted here, we also found strong geographic patterns. Among the Indian states, we found that the highest number of parliamentarians asking tobacco-related questions were consistently from the major tobacco-growing states in India, showing where the most active and prominent voices around tobacco were coming from. Our work demonstrates how regulatory measures around tobacco in India are multi-institutional and are negotiated around legitimate competing interests related to health, trade, economy, agriculture, and labor welfare. This implies a greater need for policy coherence within governments and a broad-based engagement for tobacco control with varied stakeholders beyond the medical and health fraternity. We reflect that the parliamentarian questions are a rich public resource which allows for analysis across a large time period. The parliamentary questions often provide information not available elsewhere in the public domain. And we also acknowledge that the parliamentary questions offer only a window to understand a very complex process. We are mindful that the representation in Parliament itself is a political process at every level. The presence of powerful and organized interest groups, industry lobbying, and parliamentarians' own interests and experiences shape whose voices and which voices get represented. This is especially true in a large and diverse country such as India. And this kind of analysis has provided a broad overview as well as key insights. Such data, while often used in public policy research, is underutilized in health policy research, and we believe that this could be a rich data source worth exploring further. I'd like to conclude by acknowledging and thanking my co-authors, Lata Chilgold and Dr. Upendra Bhojani, a whole team of interns who helped with this project, especially during the early stages, and our colleagues who gave key insights at various points in the project. And I would like to thank my host organization, the Institute of Public Health in Bangalore. I'd like to thank DBT Welcome India Alliance for the funding source for our project from a fellowship awarded to Dr. Upendra Bhojani. And finally, I'd like to thank Health Systems Global for creating this platform for researchers and for providing me with the speaker scholarship. Thank you.
Thank you, Amiti. I really appreciated your innovative method that you shared in looking at parliamentary questions as to provide what you described as a window into policymaking processes and the ways that those questions changed over time. And I'm hoping we can engage you in the Q&A regarding your thoughts on why the focus has changed over time and the more about the interplay between the fact that India is both a significant consumer and producer of tobacco. Now we're going to pivot away from tobacco to looking at maternal and child health in Nigeria. And Professor Benjamin Uzochukwu is going to just share with us what makes advocacy work, stakeholders' voices and insights from prioritization of maternal and child health program in India. Professor Uzochukwu is at the University of Nigeria in Nsukka. He's a public health physician and professor of public health, health policy and systems. His area of work includes health policy and systems research and analysis, implementation research, translation of evidence into policy and practice, and realist evaluation of health programs. He's a former board member of Health Systems Global and currently a member of the Ministerial Expert Advisory Committee on COVID-19. Benjamin.
Thank you very much. My name is Uzochukwu Benjamin. I'm from the Department of Community Medicine, University of Nigeria, Nsukka NU campus. I have my co-authors listed. The title of my presentation is What Makes Advocacy Work? Stakeholder Voices and Insights from Prioritization of Maternal and Child Health Program in Nigeria. As a way of introduction, the Nigerian government introduced and implemented a health program to improve maternal and child health. And this was called Subsidy Reinvestment and Empowerment Program for MCH, popularly known as SHOPI MCH. This program ran from 2012 and ended appropriately in 2015 when a new government took over. Now, this was followed by increased advocacy for sustaining the MCH services as a policy priority. Now, despite these advocacy initiatives, the role and the effectiveness of advocacy by different groups in ensuring the sustenance of the MCH program were unexplored with scarce local research in this area. It is known that advocacy is important in allowing social voice, facilitating prioritization, and bringing different forces and actors together. Therefore, the study set out to understand how advocacy works through understanding what effective advocacy implementation process comprise and what mechanisms are triggered by which context to produce the intended outcomes. Now, we use different methods for our research. This study was conducted at the national level in Abuja, Nigeria, and subnational level, Anambra State. We use realist evaluation design through a mixed methods case study approach. Now, the program theory was developed from 3 substantive social theories, namely power politics, media influence communication, and the 3 streams theory of agenda setting, then the data and program design documentation, and subsequently, all these were tested. Now, the advocacy issues that guided this program theory were, in the context of poor health outcomes, interest from policymakers and politicians in maternal and child health care, combined with advocacy and lobbying from key policy actors to prioritize MCH, is likely to help generate and maintain political and economic commitment, which ultimately will contribute to sustained implementation of and access to MCH services for vulnerable groups. We interviewed 22 key informants comprising civil society organizations, development partners, non-governmental organizations, health professional groups, media practitioners, and policymakers at both national and state level. All these stakeholders are active in advocacy events. We also mapped advocacy events at the national and subnational level, and then we supplemented this with document reviews. Retroductive approach to analysis involved continuous engagements and refining of the theory against the data and the existing literature on the subject. Qualitative data was analyzed using manual thematic and framework analysis of the main topics outlined in the interview guide. Findings were supplemented and validated with document review. And the combination of 3 substantive theories of power, politics, media influence, communication theory, and the 3 streams of theory of agenda setting, which I had stated earlier, was used to infer causal relationship within certain circumstances. Our results show that key advocacy organizations and individuals were involved in advocacy activities. The nature of their engagement included organizing workshops, symposiums, town hall meetings, individual meetings, press conferences, demonstrations, and engagements with media. We discovered that effective advocacy mechanism involved alliance brokering to increase influence with implementers ensuring the availability of MCH services. It also involved the media supporting and engaging in advocacy for adequate dissemination of advocacy agenda and the results. Also, use of champions, influencers, and spouses, leadership, and the elite gendered power dynamics to maximize result was also a mechanism. And finally, effective mobilization of citizens for demand creation. On the other hand, we also discovered that the key contextual influences which determine the effectiveness of advocacy measures for maternal and child health included the political cycle, that is change of government, because the government changed from one political party to the next to another political party. The other point is availability of evidence on the issue, in this case, maternal and child health, and then networking with policy champions and alliance building in advocacy. All these enhance the entrenchment of maternal and child health on the political and financial agenda at both the state and federal levels. Based on these results, we then concluded that advocacy can be a useful tool to bring together different forces by allowing expression of voices and ensuring accountability of different actors. In the context of poor health outcomes, interest from policymakers and politicians in maternal and child health, combined with advocacy from key policy actors, can improve prioritization and sustained implementation of MCH services. We want to acknowledge the funders, the joint DFID, ESRC, MRC, Wellcome Trust Health Systems Research Initiative, and our research consortium called REVAMP, and then, of course, the project group members, and then the respondents that provided the information for this work. Thank you very much.
Thank you very much, Benjamin. It was interesting hearing about the various types of alliance brokering and the role of the media. And I especially want to get to the elite gendered power mobilization that you discussed during the Q&A. I want to remind everyone that you can use the Q&A. You can start typing questions there now if you'd like on the platform so that we'll have questions ready after the last panelist. And with that, I'm going to turn to Marcela. Marcela Vélez is a professor at the University of Antioquia, UNED in Colombia. She's a physician with a master's in clinical epidemiology and a PhD in health policy. She's a professor and researcher and the coordinator of the Unit of Evidence and Deliberation for policy decision-making, advisor to the Ministry of Education about COVID-19, and editor of the Cochrane Epoch Group. And she's going to discuss the role of values in health policy decision-making with a multiple case embedded study in Chile and Colombia. Marcela.
Hi, everybody. I am presenting today Understanding the Role of Values in Chile and Colombia, a case study. I am Marcela Vélez, professor in the University of Antioquia. To introduce our definition of values is that values are principles or criteria for selecting what are good among different objects, action, ways of life, and social and political institutions and structures. So these definitions show that we consider values like something good that is selected by the stakeholders. We here, according to Beck, we have 5 categories of values. Basic, spiritual, moral, and social and political, and intermediate range and specific values. We are focusing here in point 4, that is social and political values. Values are important at all stages of the policy process, from agenda setting to policy evaluation, but it's not clear how they are incorporated into policy decision making about health system, and that is particularly true for Latin America, where this field is an emerging field of study. Our question was how and why social values are used in making decisions about health system financing for 2 specific decisions in each, Colombia and Chile. So this is a case study. We have selection of the country cases. We select the participants according to those that could provide more information according to the cases that we decided in each country. We interviewed those participants, and after that we transcribe the interviews and analyze it according to a content theme. So we invited 9 participants in Chile and 19 in Colombia, some of them from policymakers and some of them stakeholders. From policymakers, they come from different branches of power, executive, legislative, and judicial in the case of Colombia. We made this analysis according to our framework developed in a critical interpretive synthesis. In this critical interpretive synthesis, we identify 4 categories of values: goals, that are the values that guide the health system and guide the health system through agenda setting, policy development, implementation, and policy evaluation. All these values are related with all the different stages of the policy process. Technical values, that are values like effectiveness and cost effectiveness and other values that help to make decisions, governance values that are those related with the policy process of the development of the policy process and come from the government. That is, for example, transparency, accountability, and social participation. And situational values are those that come to be important depending on different external influences. Here we have 4 groups of values that are important, like situational values, depending on the private or public financing of the health system, from influences of other countries, on the left-oriented or right-oriented direction of the government, and the influence of interest groups. So in the analysis of the decisions, so we analyzed each decision in each country. We analyzed decisions between decisions in the same country, and cross-country analysis, analyzing different decisions in the both countries. So according to the 4 categories of values that we have, we identify different values that are important in Chile and Colombia. Accessibility, equality, equity, solidarity, timely access, and universality. And they were used like to frame the problems of the health system in meaningful concepts for stakeholders and citizens. Technical values like financial protection, that was very important in Chile and Colombia, were used as pragmatic instruments to develop the policy and decide which diseases and conditions should be included, and to determine the feasibility of implementing some strategies over others. Governance values, social participation, and stewardship were very important in Chile and Colombia, and were used to gain legitimacy in the policy development. And situational values like free choice, that was very important in Chile, it was used to influence the policy development, acting as a policy legacy. So in our findings, the principal value identified in this study were individualism, free choice, and solidarity in Chile, human dignity, financial sustainability, and stewardship in Colombia, and for both countries, effectiveness and social participation. We identify individualism in Chile as the only undeclared value, and we also identify that some interpretations of values explicitly named, like social participation, was negatively interpreted because it's considered that this value affects the consideration of cost-effectiveness decisions. So in Chile, we identified that values were also used as a way to ensure social mobility among citizens, because, for example, in Chile, they have the opportunity to choose between the private system and the public system, and this is based on an idea of free choice and individualism, but it's an idealization that they can move from the one socioeconomic status to other if they pass to the private system. In Colombia, we identify that values were used to gain legitimacy in the policy-making process in absence of meaningful citizen participation, and here was very important human dignity, like a value promoted by the Constitutional Court. So in the discussion, we identify that values are refer to many things, such as different principles, strategies, instruments, specific goals, just like Giacomini has mentioned it before. And when to have to make a decision, policymakers prioritize a small set of often competing values to make decisions. So they are not able to use a lot of values, but a small group of them. The strength of this study is that it's the first to explore this kind of issue in Latin America and was very comprehensive. And the limitation is that some decisions, like the Ricardo Soto law in Chile, was very new, and the policymakers and stakeholders has not too much to say. The study of values in policy decision-making is an emerging field in Latin America. The framework helped to make this analysis. The study is unique, a contribution to the field in Latin America, and of course the framework can help citizens to understand how values are incorporated in decision-making. Thank you very much.
Thank you, Marcella. So just to clarify for everyone that all the panelists are here and we'll be happy to answer your questions live as you type them into the live Q&A function. As you're doing that, I'm just going to start with a question of my own, and that relates to the larger question of power, which is an explicit theme of the conference and sort of implicitly pervades a lot of the sub-themes. And so I wanted to ask you all about the power dynamics within the groups that you've described. So within the Advisory Committee on Tobacco Control, among the different actors in Parliament, based on which political party is in power or which state they're representing, among the civil society groups. And I think, there are different ways of looking at this power question. There's issues related to representation, the gender, the ethnicity of those who are participating, as well as the institutions that they represent. So we talk a lot about multi-stakeholder partnerships in global health, but that can be a sort of flattening term that assumes that everybody involved in that partnership has equal influence. And I think this is, can easily be related to the values discussion insofar as Ms. Marcella, you mentioned undeclared values. It might be a way that those different power dynamics manifest, as well as the use of declared values as a way of influencing an agenda. So I welcome all of your thoughts on that. Perhaps I can see you also, if one of you is eager to answer that question right off, you can raise your hand. Otherwise, I'll go in order of the panelists. Okay, so let's start with Laura. Do you feel comfortable starting to answer that question? Okay.
Yes, Marta, thank you for that question. In our experience in the advisory committee, the way the delegates are chosen is that the Ministry of Health asks these different institutions that integrate the committee, that they are stated by a kind of law, that it's called an ordinance or a decree. And so institutions choose their delegate for that committee, and up to nowadays, the delegates have been chosen among people that are working in tobacco control or tobacco cessation, that are kind of related with the topics. So, and in general, in the meetings, there haven't been till now power issues regarding decisions. Most of the decisions are kind of consensus decisions. So both men and women integrate nowadays the committee. So there are no kind of power things related to gender nowadays. And it happened also in two times, that the person that is in charge of the National Tobacco Control Program of the Ministry of Health has been working previously in a role from the civil society or academia or another institution. So, things that go through well with officials in the Ministry of Health and the committee.
Great, thank you, Laura. Amity?
Yeah, I'd like to actually echo a little bit of what Laura said at the end about how sometimes the people who hold the positions of power are often sometimes people who have been part of the industry for many, many years. And some of these are not so explicitly, it's difficult to explicitly make these connections. But often somebody who's been on the industry of a tobacco company or one of these other groups often ends up in a position of power, making some of these important decisions. That's all.
Thank you, Amity. Marcella?
Can you hear me? Oh, yes. Can you hear me? Yes. So, of course, this is an issue that is very interesting for me. So I think that, for example, now with the vaccine for COVID, we can see the contrast or the balance between values to make the decision about how should we produce the vaccine, how should we distribute the vaccine, who is the people that is prioritized. And so I think that in every health policy decision, we have these kind of values that are declared, like we would like to have universal distribution of the vaccine and for the people that has more risk. But at the end, you can see undeclared values like profitability, that at the end, what is in contradiction and indiscretion is the profits of some enterprises. So I think that yes, for many decisions, we have something that is declared and is open, and you can see that there are an interest of the policymakers and other values that is not openly declared and discussed, but you can identify that they are playing a role in the decision making.
And I appreciate your research in trying to do that, because you're trying to name unnamed or implicit influences. Thank you. Benjamin.
Oh, yeah. Well, in advocacy, we discovered that, of course, even in previous studies, the role of power dynamics, okay? But one interesting thing in our own study is the elite, the spouse's elite power, okay? Which, the gendered power, which actually came up a lot. Because we discovered that for you to prioritize a program, you needed the buy-in of the spouses of the leaders, especially the wives of the governors and the wife of the president of the country. So once the wife of the president of the country buys into that program, it is very difficult for those at the state level to say no to the program. So a lot of advocacy events centered around them. And that was why, the maternal and child health program was able to be maintained in the political agenda as well as the financial agenda. So it is important for people to begin to utilize these sources. Before now, people had thought that, elite power is mainly about males. But now you can see the females are taking over that. So it's important to tap into that opportunity during advocacy events. Thank you very much.
Thank you, Benjamin. I think it also raises some important questions about, or potential challenges about what to do when the first ladies or those other women with power do not support the issue that we're trying to advocate. So we have a question that I wanted to read from the platform related to tobacco control and regulation from Carrie Scott, saying in India, lobbyists frame tobacco regulation as a blow to poor farmers. This presumably happens elsewhere, perhaps in Uruguay as well. On the one hand, you can see this as manipulative because the tobacco industry makes a fortune at the top and exploits poor farmers and cigarette manufacturers. But on the other hand, there are indeed a lot of people who genuinely earn a living off the tobacco industry. And in the absence of strong support to retrain them, find them new jobs or crops, they will suffer if tobacco production decreases. So how can you differentiate between legitimate issues facing the marginalized who depend on tobacco and illegitimate lobbying by the tobacco industry? So maybe it makes sense to start with Amity, since that question stems from an Indian perspective, and then we'll move on to Laura.
Yeah, absolutely. Yeah, thank you so much, Kerry, for asking that question. That's a really important question about, to repeat, how can you differentiate between genuine concerns and lobbying? And I think that's what makes tobacco control and the field of tobacco so interesting, because these are actually genuine issues. And there's a huge workforce in India, as you rightly said, working in tobacco with with actually depending on their livelihoods depending on tobacco. And I think that's where this becomes a play of power, where this is something that's known for decades, and there has been a push that how to create alternate livelihoods, how to, you know that there's a large workforce, how do you create alternate livelihoods for these people? And that's something that can be happened if it was made a priority. But over the years, even though they, to my knowledge, even though there've been various attempts, nothing so consorted. And so this remains an issue, which is, as you said, very conveniently or smartly used by the tobacco industry, where tobacco activists suddenly are the bad guys who are taking away jobs. So it's again how you frame the issue. And unfortunately, I don't think at the moment there's like this big movement to or a push to systematically change or ask for alternative livelihoods, at least in India. And maybe Laura can add about the situation in Uruguay. I think it might be a little similar, but thank you. That's a very interesting question and relevant too.
Yes, thank you very much for the question. Yes, in fact, in Uruguay, it is an issue, but in another scale, I would say. You know, Uruguay is a small country, you have 3 million inhabitants. So tobacco growers are a small group. It's not the problem, the issue that it is in India. I acknowledge that. But we know that farmers are kind of used as front groups for the tobacco industry. But of course, the issues is genuine soils that cannot be used for other crops easily. So farmers who choose to grow tobacco, they mainly cannot grow anything else. And you know that big tobacco is a kind of monopolic industry, so they offer a very cheap price for tobacco. And we also know that they use children or kids for the jobs and for the farms. And in Uruguay, it's a kind of family business in the north of Uruguay, but luckily it's more or less 50 farms and families that are dedicating to this. So what we believe, and in Uruguay we have only 2 successful experiences, but both were like kind of prompted and supported by government that are like kind of offering programs of moving to other crops and other markets. And in one case, it was a kind of cooperative, I don't know how to say that in English, a kind of cooperative business among farmers that became convert to a very different issue, but helping tobacco control enforcement. In fact, it was like the kind that they swifted to the other band, to the other team. But in both cases, the one that converted to orchards, not tobacco, and the other experience were kind of supported and prompted by programs or grants. If there isn't a kind of engagement from the government to attend this issue, you know that Framework Convention for Tobacco Control of WHO has a specific article regarding this issue. If there is no clear support, it becomes a very difficult problem, and it's a genuine problem for a lot of poor farmers.
Thank you, Laura. I'm wondering if we can kind of riff a little bit on this question of legitimate versus illegitimate and expand the question to apply to the other 2 panelists. And so Benjamin, looking at maternal child health, there are potentially health challenges included in that might be perceived as less some people might perceive as illegitimate, such as issues around post-abortion care or contraception for unmarried women, or other issues that might be more controversial from a social perspective. And I'm wondering if you encountered any of those in your work, in your research, and if so, how that was addressed, or how you perceived the tensions.
Okay, yeah, thank you very much. That's a very important question. Well, the main issue that came up, it's issues around family planning, because some religious groups do not accept family planning. And so it was very difficult for some of the advocates to in messages. Okay, yeah. So that was really a big problem. And however, what was very prominent or very important was that there was already a maternal and child health program, that's within the National Strategic Health Development Plan, that has been approved. So it was like a national program, okay? So coming down to say, oh, we don't want this, okay? Because it's already a national program. And this national program within the maternal and child health was truncated, okay? Because of change of government. So what the advocacy specialists were trying to do was to make sure that these maternal and child health services continued, okay? So, and that included the family planning, okay? Even though it was an issue trying to convince, some of the, those that have power to take decision, okay? Yeah, there wasn't really much they could do because the other people were in the majority and were able to convince them that, look, this program should continue. So if you want to access the services, fine. If you don't want to access the services, that's also fine. But the program should continue, at least for those who want to access it. Yeah, thank you.
So it sounds like the global strategies and the way they were reflected at national level, similar perhaps to the Framework Convention on Tobacco Control, provided a framework that everyone could agree on to try to support some of these more challenging issues. Marcela, do you have any thoughts on this question that you want to share? Of legitimate versus illegitimate and the perceptions and the way that those are framed?
Marta, I have the feeling with the, what's the name? The general session that we have at the beginning of this day in the symposium about the, for example, sweetened beverage, that maybe in the regulation for tobacco and for sweet beverage, we have also this kind of contradictions between what is necessary for the industry and even for the no multinational industry, but for local industry, and they have their own interest in the policy decision making. So I think that health systems have to balance the interests of these companies, even the companies that help to the workforce at the interior of the country, with the needs that people have for maintaining the health status. So it's not easy, and it's not easy to put in the balance the values and the interests of one of the stakeholders and others to make transparent and accountable decisions. But I think that it should be very clear for everybody that there are different points of view or values to influence the decision.
Thank you. Laura, I don't know if you want to add anything about the way that you tried to prevent the capture by industry in your advisory committee from the beginning, if there was something about the design that prevented that.
Right now, there is a project going on, but it's from an NGO that its delegate is sitting in the advisory committee, but it's a project not from the committee, but from that NGO, from the civil society, that is a kind of monitoring tobacco industry interference, and it is looking at several processes and trying to get a tobacco interference index. I believe it's a project that it's done in other countries too, and it's supported by a very big NGO that it's called Tobacco for Kids. Maybe you know it. And so we are kind of looking at that index, a standardized index for tobacco interference. At the local level, what we prompted from the committee was that officers from all ministries had to sign a conflict of interest and transparency agreement regarding specifically tobacco industry. That was a kind of proposal from the committee. It's not yet enforced, but we realized some years ago that everything was going okay with Ministry of Health, and we had some projects going on and moving forward. And then inside Ministry of Economy, there was a lot of interference from tobacco industry, and so laws and proposals were kind of stopped there. So we, what Amity said about different ministries and different areas looking at the tobacco control issues is very important. You have to address all those power places to move forward in tobacco control. And I think that signing a kind of declaration of conflicts of interest and transparency regarding tobacco industry under the principles of FCTC, you do not have to invent a new thing about this. Under those principles, would be a good thing to implement.
I'm wondering, so there's about less than 15 minutes left, so please take this opportunity to ask any questions that you have in the live Q&A. I wanted to just pivot to the question of the media, which Benjamin mentioned explicitly, and the extent to which the media reflects those power dynamics that we've been discussing. And I don't, there's this question of industry influence, there's the question of, Benjamin, you mentioned religious leaders. I do not mean to compare religious leaders to tobacco industry, but just the sort of different centers of power and perspectives and how that may have played out with the media, which in many cases is also a for-profit enterprise.
Yeah. The media is a very powerful group that in health cannot be neglected. Okay, so you must have the skills to navigate, through them, because if you work with the media, they are likely to propagate your message. But when you don't work with them, therefore they don't understand what you're doing, they can misinform the public. And once they misinform the public, then your program is in jeopardy. So for advocacy purposes, it's always very, very important that you engage the media. Engaging the media means using your evidence, using available evidence to convince them that this is this, okay? And then handing over the evidence to them so that when they are disseminating the information, they are disseminating exactly what you have given them without distorting it. And this is very, very important because at times, if they are not well informed, they can distort the messages and then pass the wrong message. So in most health programs, whether it's in tobacco program, whether it's a maternal and child health program, it is important that the media are well informed of the program. Thank you very much.
Does anyone else have anything to add to that? And I think, another question to explore is the media's potential role as an investigator to uncover some of these in questions of influence. Amity?
Yeah, I'm happy to come in. I think as you were mentioning, and as Benjamin also mentioned, the media is an extremely powerful tool, and it's important that it really has the power to shape narratives. I think we see that today in any field, whether it's with maybe narratives around political parties, environmentalism, tobacco control, maternal and child health, or any other health issue. It's a very, very powerful tool which can shape how the public thinks about certain things, and that's when they get behind certain ideas or not. Including with coming back to the earlier question, talked about how do you know if a concern like farmers and alternative livelihoods in India is a real concern or not. The narrative around the media can potentially, if influenced by the industry, can shape the narrative, and the large amount or the public can believe certain, maybe believes that the farmers, this is taking away livelihoods. So it's just trying to reiterate that it is very powerful, and within the field of tobacco too, it has played a huge role over time in shaping the narrative. If you look historically, even maybe in the mid 1900s, where tobacco was marketed as being a beneficial product, which had so many health benefits, or it was something that was marketed to be used. And I think now that has changed with both laws in India and with the FCTC, where there are very strict guidelines on how the media has to represent tobacco, and it cannot, tobacco cannot be something that's advertised, and there are very strict guidelines on if at all tobacco is mentioned, how it is mentioned. But just to reiterate, yes, it is something that is very powerful and definitely needs to be monitored because of the power that it holds.
Thank you, Amity. Laura?
Yes, just to add to ways that media was used here in Uruguay for tobacco control and for tobacco advertising. Unfortunately, here our law has a very complete ban in advertising, promotion, and sponsorship, even in the point of sale. But we have been realizing that there are a lot of influencers in social media, in Instagram, Facebook, that they look as if they were paid for the tobacco industry, but we cannot legally consider that is a promotion or sponsorship or whatever, but it's a kind of local or regional celebrity saying, well, today I'm vaping this new device and whatever, and they look like cool and they have millions of likes, and well, that is a kind of covered sponsorship or advertising that we have to address and find a legal way to tackle it. And on the other side, we made last year a campaign, a media campaign for youth, and we had a kind of professional communication business or enterprise that was like kind of dedicated to social media. And they made kind of posts and spots and videos for the young people. And it was very interesting how they explained us that the segmented message was very important. I said, well, I'm not seeing the videos. Well, Laura, you are not supposed to see it. You're not in that age. You are not the target group. So they are not going to come up in your Instagram. But after the campaign finished, they showed us all the evaluation, the kind of posts and likes and visualizations, and really it's very important to have professional assessment in all this communication and media issues in the social media.
Changing media landscape certainly complicates. Marcella, do you have anything you want to add on this issue?
I know that you do questions about tobacco, and I answer with values. But the thing is that, of course, they play a role. And now with the media, for example, we have identified, so for many people, it's important what the media is moving, and that changed the mindset about what is important in their lives. For example, here with tobacco control, we have this movement of different people that says that the right to their individuality, it has been affected by the decision of prohibit the smoking in some public places, and they are moving this like a value that is important. Yeah, that there is a right that is violated for these people that wants to smoke, and that they present this in the media, and there is people that of course understand this like a contradiction between the right of people to have a healthy environment, and the people that wants to develop the right to his or her individuality.
Great. So I perhaps that's a good note to end on, of sort of zooming out and making it, again, complicated as we grapple with these significant social issues, and how those are arenas in which power plays out. And I think, what's really exciting about this year's conference is that there is a lot of this zooming in and zooming out and looking at the way that these dynamics and influence on our manifest in health policy making and implementation processes, but really relate to significant social interactions that happen in much more writ large. I don't see any more questions in the chat, so I think we can end 3 minutes early. I know for most folks on this session, it's the end of the day, but we do have 3 minutes left. So if any of the panelists wants to make a closing thought, please feel free. I can see you all, so you can just raise your hand and I will transfer the mic to you and you can do that. Nobody is raising his or her hand. Benjamin?
Well, just to say it was exciting listening to everybody, especially the tobacco group, and I really learned a lot from their presentation. And I hope we'll keep in touch. And then Marta, thank you for your excellent facilitation. You brought up a lot of questions that the listeners, the attendees did not ask. And then, of course, we had to throw more light on them. So thank you very much. Thank you, everybody. It was nice meeting all of you. Thank you. So I'll continue to enjoy the conference.
Great. I think a note of thanks is a superb one to end on. Amity, do you want to?
Yeah, absolutely. I'd like to echo what Benjamin said. I think it's been a wonderful opportunity, and I feel like I've learned so much from all of the panelists as well. And thank you, Marta. It was excellent facilitation on your part. Thanks for making this process very comfortable.
Great. Thank you to all the panelists. Thank you to HSR for your tech support. And thank you all for attending. I hope you enjoy the rest of the conference. And we'll see you virtually in other spaces later. Thank you.
Thank you very much.